Welcome to The Explainer. Today, we're jumping right into a challenge that pretty much every physiotherapist working with dizziness and imbalance grapples with, and that's gaze stabilization training. This episode is based on gaze stabilization training, principles and prescription, mechanisms, exercise library, and outcome measurement published by Australian dizziness clinics. We're going to break down exactly how this mechanism works, and more importantly, who it actually works for. So let's start with a scenario we all know way too well. It's a classic clinical headache. You've got two patients, they present with seemingly similar dizziness, and they both perform the exact same gaze drills. But while one recovers beautifully, the other just completely stagnates. Why on earth does this happen? Well, our immediate assumption is often that the second patient just isn't trying hard enough, right? But honestly, the difference is rarely a matter of patient effort. The success of gaze stabilization training hinges entirely on whether the vestibular substrate, the residual gain, and the patient's phase of recovery were perfectly matched to the exercise prescription at session 1. Think about it. If you prescribe a drill that the brain physiologically just cannot learn from, effort really doesn't matter. To help with this, we've got a decision-making framework for today covering 4 key areas. 1. Indications and substrate. 2. When to substitute. 3. Phase effects and recovery. And 4 are key takeaways. All right, let's get into Section 1, Indications and Substrate, and how we identify the right candidates. Take a look at this specific number range right here, 0.3 to 0.7. This is the absolute sweet spot for residual gain on a video head impulse test, or VHIT. Unilateral hypofunction within this precise range is our prime indication for gaze stabilization training. If their gain is in this window, that pathway is primed and ready for classic adaptation exercises. And that leads us to the specific diagnoses that actually fit this profile. Patients with things like vestibular neuritis, post-labyrinthitis, and schwannoma resection, they benefit the most. It's also a strong indication for the post-concussion vestibular subtype and even vestibular migraine. But, and this is a big but, provided you actually confirm the hypofunction. You absolutely must confirm the side and degree of the deficit first. Do a bedside head impulse, a DVA test, or ideally a VHIT. Gaze stabilization training is highly mechanism specific. If they don't have measurable gaze instability, they rarely need it. Which brings us to the core neurophysiology. When VOR gain is mismatched to head velocity, the image of the world literally slips across the retina. And here's the thing, the cerebellum needs this retinal slip to learn from. It acts as the error signal that actually drives cerebellar plasticity. This is exactly why having that measurable residual gain we just talked about is absolutely mandatory for adaptation. No substrate means no error signal, and no error signal means zero plasticity. Okay, moving right along to Section 2, when to substitute. What do we do with minimal residual function? This clinical algorithm from Australian dizziness clinics is incredibly helpful. It illustrates a fundamental fork in the road, showing how residual VOR gain explicitly dictates your path. Just look at the top there. Is residual VOR gain present on the affected side? If yes, great, you move down the adaptation track. But if no, meaning it's minimal or absent, you have got to switch over to the substitution track. So we really need to understand substitution. You pivot to the strategy when gain is severely reduced bilaterally or completely absent. We're talking cases like bilateral ototoxicity or post-resection without residual canal function. Pure adaptation just isn't possible here anymore. Instead, you're essentially teaching the brain to rely heavily on non-vestibular cues. That means explicitly training for anticipatory saccades, where your patient deliberately saccades to the target before their head even arrives, as well as harnessing the cervical ocular reflex and proprioceptive cues. Next up is Section 3, Phase Effects and Recovery. Let's talk about timing the intervention. The timing of the injury completely changes your therapeutic prescription. Striking in the acute phase, so under 3 weeks from symptom onset, that drives the absolute steepest recovery curve. If you delay beyond 8 weeks, you actually have the rate of recovery. And as your patient transitions past 12 weeks into the chronic phase, pure VOR adaptation alone just isn't going to cut it. You must shift toward more complex, dual-task contextual training. We track these recovery phases using the strict outcome battery every 4 to 6 weeks, which lets us know exactly when a patient has hit a plateau. You can see we use objective measures like DVA and VHIT right alongside subjective, patient-reported measures like the DHI for handicap and the ABC scale for balance confidence. We're hunting for very specific, meaningful changes here. A one-line gain on the DVA, a V-hit gain getting back to 0.79 or above, an 18-point drop on the DHI, or a solid 10-point gain on the ABC scale. And here is a massive clinical pearl for you, derived straight from matching up those test results. Let's say you retest at 4 weeks. The biomechanics, the objective DVA, respond beautifully. But the patient tells you they don't feel any functional benefit, which shows up as a stagnant DHI score. That is your trigger. Do not just keep giving them more of the same seated VOR drills. That data pattern is telling you to escalate the standing or walking layers to integrate that improved reflex into their actual daily function. Finally, Section 4. Let's quickly summarize this framework with some key takeaways. If you remember anything, make it these 3 golden rules. 1. Verify the unilateral vestibular hypofunction and make absolutely sure there is a measurable residual gain to act as a substrate. 2. Immediately substitute when that substrate is gone or bilaterally reduced. And 3. Always adjust your prescription based on the phase of recovery. Leverage that early acute window for pure adaptation, and then add heavy dual-task context for your chronic patients. So what's next? Now that we have the patient selection totally nailed down, in Explainer 3 of this series, we are going to take these exact principles and apply them directly to the exercise library. We'll be walking through the specific dosing and progression rules for X1 viewing, X2 viewing, near-far transitions, and how to effectively layer in complex, busy backgrounds to really drive that adaptation. For the full literature review, the complete exercise library charts, and plenty of other clinical resources to support your practice, visit AustralianDizzinessClinics.com. And please remember to subscribe and rate this explainer if you found this breakdown helpful. I want to leave you with one final thought before your next clinic day. When a patient isn't progressing, ask yourself, are you prescribing based on perceived effort, or are you actually letting the physiological vestibular substrate guide your clinical decisions? Always remember to let the underlying gain dictate your path. I'll catch you in the next episode.